is breast cancer. And that goes to about 15.9%. The next one was cervical cancer. You must have come across this patient before. Then prostate, liver, then other. But these are the majority of type of cancer that you are going to see and pick. As a matter of fact, when we started palliative care here, because we want to actually empower, we were not doing palliative care for HIV patients, for cancer patients. Because it took some time for us to get cancer patients. Whenever there is a cancer patient here, what they do is that they send them to UCH. You cannot manage cancer here. So we actually started with HIV/AIDS. But it was later we pressure said, no, what is in cancer? Why should you always refer cancer patients to UC? You disorganize them, you disorganize the family. Let us try, and that is how cancer management, build up in the system. And we even have oncologists in the center now. So you start very small. Definitely you are going to get there. When we started, we were working mostly with HIV/AIDS. Do you know what the referral consultation we are getting? Please come and be bad news for HIV patients. That's what they are telling us to do. And we are bringing bad news for HIV patients. The HIV patients were not allowed to do so many things. They were not allowed to theater. They were blocking them. I know Dr. Rene will remember that time. But when we get as a team, they agree. And everything is going on fine. And people even came from outside. The organization, one body came from outside and said, you people are doing fine here. And they partner with us. And that's how it started. But most of the time, it's cancer patient that you are going to have. And we did a study in this center. In 2005 to 2008, it's still the same thing. Breast cancer is the highest in number, followed by cervix, liver, prostate. So that means our own local study is also in line with the global curve. That was what I was trying to tell you the first time. So this, the 2-year study we did was on 52. No, this is one of our experiences. We are going to have a lot of experiences. We tell a lot of stories in palliative care for you to know. So you don't need to write things down. You put it in your brain. Let me give you an example of a patient we saw here and what we have done within that period. There is far back. We are very lazy there anyway. We had 92 cancer breast patients in the center, in and out patients. Female 190, male are 2. How many of us have seen male that develop breast cancer? Cancer of the breast in male. How many of us have seen? Yes. They are not very many. As you remember, there was one KBC that used to be our patient. We are very close. He died of breast cancer. I think this year. He's our friend. But I was so sad because it's not that very good. It's not as good as that. Yeah. So you see them, and when you see them, they are usually very bitter. It's not a very good. They don't have good prognosis. The maximum age of our patients 70 years, and the minimum, we see cancer in 12-year-old. Things are changing. So the mean age of cancer of the breast we see here is 49 years, and 65% of cancer patients we have here, they present in advanced stage. And if you go into the literature, all the publication in Africa, 60 to 70% of cases we present at an advanced stage. And you know what I mean by an advanced stage? I have some pictures here to show you. Because when we are doing this program, sometimes ago with Ogun State Management Board, they brought people from primary and secondary. They never see this kind of picture of cancer patients. And we intend to give you these pictures to actually sensitize you. So, Commonly, what we are going to see, they are breast cancer patients. And we intend to take you through the process, how it starts, the trajectories, and how it ends for them. Because you may meet them very early. You may meet them midway. You may meet them at the end stage. But from the literature and the research we did, which of course I cannot show you physically, graphically, is that 65% of them will come to you at an advanced stage. If we have time, we discuss more about advanced stage. At advanced stage, there is nothing more you can do in terms of curing them. So what you need to do is palliative supportive care, and that is where palliative supportive care come, so that they don't die in pain and they die peacefully with dignity. That's part of the philosophy. The recent study we did here, a 3-year review, I think that was the last one we did, 2015 to 2017. The number one cancer is also breast cancer. And that was 38% of all the cancers seen. PSC is coming up now. Cervical cancer is always there. Ovarian cancer is always there. And the prevalent group is coming down now. We used to know that cancer is the same in old people. But nowadays, we are seeing cancer in young individuals. So you have to look for it. And they have various symptoms, which when there is light, I will show you. Now, how do you see them? Let us do it like this, because that will be interactive. How many of you have seen cancer patient before? Okay, almost everybody. What type of cancer? Yeah? Commonly breast. That's what the scientist is telling us. It's usually commonly breast. At what stage are you picking them? Late stage. Late stage. Yes, that's what the teacher said. Even our own study here showed that it's 65. And that is why at that point in time it's almost impossible to cure. And that's where palliative supportive care comes in. Now, as somebody tell us, those ones that you have seen, what are the problems they have, the symptoms that tells you that this person is suffering from cancer? You have to pick it from the basis, because you are going back to do it. What type of symptom, sign do you notice in them? Anybody want to tell us? Complain of pain. That's good. So you will not be surprised when we say our department is pain and palliative medicine. So we take pain very seriously here. Any other thing?
Loss of weight.
Huh?
Loss of weight.
Loss of weight. Good. Any other thing? There are many.
Breathlessness. Severe weakness of the body.
Eh?
Severe weakness of the body.
That's good. Any other one? Breathlessness. Okay. Any other one? Ulcer.
Loss of appetite.
Loss of appetite. You see, it's because the thing is not flowing very well. What would have given you is how those things develop as complication. You understand? Even in picture. When you talk of advanced metastatic cancer, that means the cancer has grown from the primary source. I will remember, I've forgotten the year, but not too long, a very big man in Ogun State here. In fact, one of those people who gave this hospital to us from state just walked into my office and said that he's weak, he's happy, and all those sorts. And I said, Baba, you have cancer immediately on your body. In fact, I can see cancer in your bones. Cancer? Where do I get cancer? I said, well, it's possible with your cancer of the prostate. He said, cancer of the prostate. Now, he removed his prostate about 10 years ago. I said, yes, you removed it about 10 years ago. But you have cancer not only in your prostate, you have cancer in your bones. I don't need to ask you to go and do tests. I don't need to ask you to go and do anything. Because we know how it flows. It's an experience. Just like we started 2001, 2023. So the man said no, that the best surgeon in usage remove that prostate. I did that surgeon. That surgeon is a professor. In fact, I did for one of my friends recently. So I said, okay, before you meet your professor, just go and do CT scan for me. So now available here, go and do it in Babcock. The man said, what is this one saying? Went to usage, met the professor. And the professor said, no, that doctor does not know what he's saying. That's okay. I'm not a professor, but I know that a professor is in a monolithic area. He has a narrow space. The guy is an urologist. There's a difference between urology and uro-oncologist. I'm a palliative care oncologist, and I've seen a lot. I can't remember the number of cancer I saw. Then don't forget it. I mean, just forget it. He doesn't know what he's saying. Where? Private medical center. So they don't be here. So the man, they don't do CT scan. Just go and do bone scanning. And unfortunately, at that time, the machine for bone scanning in UC did not work. And they waited for about 4 or 5 months before they do bone scanning. I'm not talking about his prostate. The prostate has been removed. And I told him he has cancer on the bone. It is the prostate cancer that goes to the bones. Those are the things we want to teach you, how it goes. You understand? Because it's not about lecture, it's about experience. And behold, all the bones, just like I have said, I do bone scanning. I didn't do CT scanning, but I know when you present this is it. We decode it. It's like this department, we decode it. You see like we decode what is wrong with you. And this is a gift given to us by God. So, metastatic bone cancer. And it was too late. So we facilitated radiotherapy in Ibadan. Wanted to go to America, it was late. But keep this thing to you yourself today. I'm saying it boldly. Most time, cancer does not have remedy. We just pray that it doesn't come to us. Of all the fathers where I grew up, it was only man who reached 85. He got his prostate removed when we were young. But at the end of the day, it is that same cancer of the prostate that killed him. Because when they remove, they leave some there and they grow. They said they have remission and it grows back. So you have to be cautious. You have to have that clinical acumen. It's very interesting. Some of us cannot do any other work because we get results. Even we are not professors, but we do better. So we talk about the bothersome symptoms. We have talked weight loss, anorexia, chronic pain. Then what about the socio-economic issues? Can anybody tell us about socio-economic issues that the cancer patient might have? Socio-economic issues.
Financial constraints.
Yes, financial constraint. I was reading in newspaper recently how much it costs to buy asthmatic drugs. You can imagine how much it costs to buy chemotherapy. I could remember when we were buying the chemotherapy for a colleague, 1.2 million, just a shot. So you can see the problem. The family gets drained. And the problem in palliative care is that it's a family, patient and family center. So the patient suffer, the family equally suffer. Then besides financial social issues, social discrimination, some people when they has cancer, they run away from the evil. Then we'll be talking about breast cancer. What about body image disfigurement? We'll show you some of those pictures. But image disfigurement, we don't even discuss about their sexuality as well. Their sexuality is also very important. Then they ask themselves question, why? Why should it be me? I'm a Sunday school teacher. I serve God. Why should I have cancer? So those are the things that ruminate in themselves. And they give them a lot of it. And every human being is a spirit anyway. Every human being is a spirit. So every human being is spiritual. Forget about religion. So the spiritual aspect of it is very, very important. And we always discuss what we call existentials. where am I going? Assuming where do we want to go? Where are you going thereafter? So those are part of the problem, and that is why we need the psychologist, we need the chaplain, we need the surgeon, we need the social worker, because it's only a dishonest doctor that will tell you that he can securely manage a cancer patient. I can do it, and at the end of the day, they shortchange the patients and their family. They just waste money, they die in pain. We are going to go into that when you get into ethics in palliative care. So then the challenges of radiotherapy and chemotherapy, we have mentioned it, the cost, which is not affordable. So besides the breast, liver, prostate that we have dealt with, I also want to take you to HIV/AIDS related cancers. We have the picture. We publish papers on it in this center. These are the things we are going to go through when we have light. And these are part of the thing I wanted to show you. Not everybody can see, but you are going to see it. You are going to see it. So that is just testing the ground on what. Then can somebody tell us what is the relevance of palliative care in HIV/AIDS, HIV medicine? Anybody? If you go to your center now and you decide that you want to start palliative care, you don't want it to be for only cancer patients. You want to introduce it for HIV patients. How would you justify yourself and convince your CEO to agree? Nobody? They are guru.
HIV is a multi-systemic disease. HIV is a multi-systemic disease, and HIV clients also have a lot of pain, both physical, emotional, and psychological. So most of the time, the other physician will concentrate on the physical pain. So palliative care is needed to come in to manage the other aspects of pain, the emotional, the psychological. And then we should not forget that in HIV, stigma and discrimination is a major problem. Palliative care comes in there. And also with HIV, as they grow older, because now HIV is not a terminal disease, but as they grow older, they can have other comorbidities which needs a more holistic approach to manage.
I'm sure everybody agrees to that. Yes. To be modest, when we wanted to start managing HIV here, people were fighting. Community health says their own, family medicine says their own. I think well, from my own experience, it's a multidisciplinarity. Everybody has a role to play. And they said, okay, go and start it. We started with maybe about 3 or 4 patients. And within 2 months, we have 75. And I'm sure now, if I still have patients before I left that have been managing since 2006, HIV patients. They are still alive, the clinic, 2006. And most of the time, what they give them is hearts. You don't go into the background of the prevailing circumstances that they are passing through, like Dr. Irene said. If you have time, I will tell you, we share a story with you about one HIV patient. In fact, there was one that even decided to commit suicide and jump into Lagoon in Lagos. There are so many of them. Because they are not well managed. You understand? So, and let me read to you what Pepper said about palliative care. You know Pepper was one of the front line in the barricade. He said palliative care in HIV aims to achieve optimal quality of life. That's what you say. Some of you said you want to see how you can give good quality life to patients. Quality life to the people living with HIV and their families. Minimize their suffering by mobilizing clinical, psychological, spiritual, social care through the entire course of HIV infection. It provides routine monitoring, initiation of treatment, Palliative care includes and goes beyond the medical management of infectious, neurological, and oncological complications, what they are saying, frailty, to comprehensively address symptoms and suffering throughout the trajectory of HIV disease. That's not my own, that's Belfast said it. And it took us a long time before they accepted us into the practice. And to the glory of God, till now, we started in 2006, till now, we still run our clinic HIV on Tuesday. So for those of you who are not within this sector, it's an initiative you can take along. Palliative care, you can use it. It depends on how far you are innovated about it. And this is, I will show you, this is one of the paper, because I work with AIDS Relief, Catholic AIDS Relief. They were taking care of HIV in the Southeast. I was their director of education. That was between 2004 and 2012. We wrote a paper, you can see my name there. That was with the University of Maryland in US, Baltimore. And the title of the paper is Implementation of HIV Palliative Care, Interprofessional Education to Improve Patient Outcomes in Resource-Constrained Setting, University of Maryland. So, they are emphasizing interprofessional education to improve the outcome. And this is what we are doing here. It has always been on. Then, we are going to break into sessions after giving you all the rudiments that you need. In palliative care, we do not diagnose. We see a patient and identify the problems. And we work on those problems. I've told you of a Babana that has this. These are the problems. How will you solve? How will you ameliorate so that I can have a quality of life? Let me give you an example. We have a 39-year-old male, HIV-A positive, presented with ulcer on the right foot. I will show you later. Ulcer on the right foot. The CD4, I know they don't do CD4 again now. The CD4 4 years ago was 275. So you can imagine why that ulcer comes in. The CD4 on referral to us, that means was picked up at 275. On referral to us, the CD4 was 84 cells per microliter. And we made diagnosis. It's no more an ulcer. We made diagnosis of Kaposi sarcoma with HIVs. Those are part of the HIV-related cancer. So, not like I've told you, it's only a dishonest person that will say you can manage such a patient. In other sector, what they've got to do is just to continue to give heart, and the patient goes home. As a matter of fact, it's because of our networking, partnering with Yai, partnering with Lantoro. You will see all those pictures. The patient came to us from Lantoro. So we co-manage here with our dermatologist. And the patient received chemotherapy. 4 weeks post chemo, the CD4 went down to 16 cells per microliter. Then later to 89. It's building up. You can see the picture here. You are going to see very soon all those things. Because we are not going to teach. We want to do experiential learning. We want you to learn from our own experience. Then other HIV-related cancer, this patient I'm telling you, we also publish it in this department. You see, journal, we publish it. So other HIV-related cancer is non-Hodgkin lymphoma, CA cervix, and so on. So it's very easy for you when you see. Let me give you one or two things. These ones are very important because you are going to solve cases. Let me rush through this one. Mrs. FM, 30 years old. Please listen very well. 30 years old, has 2 kids between 4 to 6 years. as right breast lump, which was, we had a excisional biopsy, stage 1 in 2006. Then local excision was done, had adjuvant radiotherapy with 6 courses of chemo. Despite the 6 courses of chemo, months later, the chest pain crawled up, and the bone scan, as I said now, showed metastasis and was given radiotherapy. That's part of the treatment for metastasis to the bone. In January 2008, that is 2 years after, she developed bilateral pleural effusion. You understand and imagine that sequence: breast cancer, chest pain, bone metastasis, and later she developed pleural effusion. Who can tell us what happened? It's a sequence. In fact, the bone metastasis came before the pleural effusion. Who can tell us what happened there? I don't want Consultant to talk, but they know. Who can tell us what happened? The Yoruba will say cancer is what they call jejere. It eats up the whole body, and this is a typical case. Breast lump, excisional biopsy, chest pain. That means it has left the breast. It has gone into the bones here. There is metastasis when the scan. He had radiotherapy. Radiotherapy is also good for the pain control, as you will see. Then he developed pleural effusion. Now, when a patient develops pleural effusion, something that I'm going to take too long. When a patient develops pleural effusion, what does it mean? For those people who know how this thing goes around, how are you? When somebody develops pleural effusion, what do you think is going on? Pleural effusion, anybody? All these things, you can see that in textbooks. For 2 years, you won't get it. All these things we are giving you, you won't get it. It requires the glue to break it down for you. And that's what we are feeding it. We are going far. You have not started. This is just the way you have appetite. Pleural effusion in your patient breast cancer. What does it mean for it, man? Yes. You are talking of bone. You are talking of chest. It has gone to the lungs. And when the cancer goes to the lungs, what do you expect? Because there is fluid there. And that is why part of the story is that we have pleural effusion. So there is no magic about it. So we remove the spray. I mean this one. Can you see? You see sharp now. It's that color very sharp. Blue color. Okay, maybe you have to do it. So what we are saying that it's very easy to understand these people, because any complication you see, you know where the complication is coming from, and you can follow it in sequence to actually know when and where you want me to do. Because I have bad reading. Okay, that's this is an employer. Yes, just like I've said, these are the people's expectations. We have more than, you see, these are your expectations. All these expectations that you are seeing, I beg, he already become a specialist. And my training took me 3 years to even have that skill. But we try our best within this short period. Now, I wanted to talk about the PSF. You can see that the people are very few. Unfortunately, the day we started, strike happened. Despite strike, you see the number of people that attended, and that is Professor Ogun, who is very good. That's my good friend, but most of them are consultants. And the man you see at the center, who came from UK, he came to the ground, Vessel UK. That man was 69 years old when he came to us. He was a surgeon and decided to stop being a surgeon and start taking of people that are dying. I don't know why he's there, but very old. Then we started working with the University of Kent. That's my boss. He actually told us, when I do my entry, you have to supervise something. The one in South Africa, the one actually opened it for me. He's a professor. So the only professor now. He always get grant for us from British Council. And the British Council was actually funding him to go. So that's what we did in 2008. You can see the medical director, the CMA. And we also went back to usage at that time too. We do training. That's Professor David Oliver, Professor Shinabu. We are working together, and that is Ogun. Ogun was the dean there in UCH, and that's how they were from the Simba. The lady by the side of David Oliver, that's Dayo. She's in Nigeria. She's not from Nigeria. David will not come. As far as 2008, they don't want to come until he brings in Nigeria for you to have confidence in coming. In 2011, a different thing again. So that's how we have been doing. And I said to this idea, why did you? He's saying here, and I think that their director of nursing there, Dr. Kuka, I'm sure some of you can see there. This is also at the guy. This is Atlanta. You have not told the Reverend Father is a friend. We always go to UK together. Here. That's Elijah. And that's the doctor. So that the student nursing and all those. It is bedside teaching. So you have a college of nursing now. You can see the student nurses or the work. So we've been doing it for a long period of time, and we also go to UK for training. And these are the major also Palliative guys gather that is in Africa. We are all here. Any guys that are training before, we be here. So you are also going to benefit part of the clinical placement. These are part of the bedside teaching for patients. I mean, bedside teaching for our participants. We hope we are going to reenact this as well. And this is when Ogun State Health Management Board sponsor us. We have a lot of people from there. And that's Dr. Ibu, I think retired as head of service also. For those who are interested in home-based care, this is one of our home-based care. I think it was ordered that we always go to different houses to take care of people, and that's why I told you that okay, we have done all those. Okay, these are the things I will show you. Breast, very high. Are you see? Body or symbol? We copy this from textbooks for our patients. On admission, 10 days after admission. In a suicide patient. Different faces. Okay, breast cancer. You see, when we are showing this thing, in one of the, when the state sponsored, people came from primary care center. They said they have never seen human being like this before. They are there. And that is one of the reasons when we started, that 65% of them present at an advanced stage. And we are seeing it going to the bones, we see it going to the lungs. So those are part of the body of cancer, abdominal cancer. You see, this is a perineal mass. You see how human being can be suffering. Then we talk about the HIV day. Pre-heart, within 6 months, the cow goes down, they die. But post-heart is entirely correct. Period of getting well, period of getting bad, and they live and live on. I've shown you. Okay, this is what the people are telling you that I wrote the verse of maybe like I see my name there. Then this particular one was very. We published it in the department, that was 2018, and that is the ulcer we are talking about. Not really that it's a taboo support. And see the leg as it was getting worse. We also, we published it in the paper. You can see one leg, a very big man, very rich person. So this was the one we were discussing. And we talk about carcinomatosis, lymphangitis. I think there's another example. Breast cancer too, R5 causes, presented, I'm not blocking anybody. Presented with severe abdominal swelling, massive ascites.
Okay, the pan is broken. Okay.
So massive ascites. We were talking about pre-erection before. It also causes massive ascites. Some of them develop hepatomegaly as part of the trajectories. In this patient, 6.8 liter fluid was aspirated over 4 days. Ascites treated with lysis and spironolactone. Those are part of it. Okay, thank you. Repeated X-ray, abdominal scans show minimal ascites, no pleural effusion, is just palliative. You see come back. Now let's go to the issue of palliative care. This is the father of modern palliative care hospice. This is the son that started a facility in 1960s, late 60s. She was a nurse, and when she grew up with spinal disability, she decided to become a social worker. And from then she realized that people died, they suffer a lot of social equation and pain. And came out with the philosophy of palliative care. And people say it's not going to work, but doctors are not going to take it. So she eventually became a physician. And that's why you see that the concept is very grounded. She had an experience as a doctor, she had experience as a nurse, she had experience as a social worker. Very, very complete. So palliative care specialty became known in UK as far as 1987. It's not the specialty in Nigeria. I tried. I got grants 5 years in 2006 to start the faculty in Nigeria. They did not agree. And that's why people are suffering. You have to go to abroad to get the certificate. So, I'm jumping somewhere. So let's continue to go. Part of our philosophy, the philosophy is that you meet nurses at the labor room waiting for a child to come out. The father is there, everybody is there anticipating the child to come out. But when that soul is going to the other side, people run away from them. So we have midwives in the labor room. We are the midwife to the other side. We are used. We stay with them. So this is the principle of palliative. I won't bother you with it. You can always check it. Affirm life, regard dying as normal. We don't hasten death, we don't postpone death, so there is nothing like euthanasia. It is applicable in all causes of illness. We have said it, HIV, everything, you can use it. And this was the Greater Declaration by Africa. Palliative care is a right of every adult and children. It must be accessible and affordable. I know that so many of you have been seeing patients that benefit, but they are supposed to benefit, but don't give them. And it is, you must control their symptoms as a human right. And some people are already doing that. You see palliative care as a fundamental human right. But in some center, you will see somebody holding on to the patient, knowing very well that this patient requires palliative care, they will not give. And in the law now, it's like we are violating that person's human rights by not giving it. They do it every way in this system, they deny them from having access to it. And that is why we are here. All members of healthcare teams and providers, they need training in palliative care, so we are welcoming. Palliative care should be provided at primary, secondary, and tertiary level. We fought a lot to get to this level. There was no palliative care in Nigeria for years. But recently, with sensitization and advocacy, I think 2021, the national palliative care policy came out for the first time. And the government prescribed that palliative care should be provided at the primary, secondary, and tertiary level. If you want the policy, we get it for you. You go back to your center. Federal government has said that at the primary community clinic, there must be palliative care. So for those who want to specialize in the field, the government is backing you. In fact, our next strategy was to move into primary care level with our community medicine departments here, but that project did not work. We are in secondary, so we will be hearing you. In fact, I was talking about 2 days ago. Now we should be having conferences like this. You transmit. You are not transmitting into your school today. In nice places, you sit down like this. We discuss cases in Nigeria. You view us, we view you. We discuss. I think we learn of that in Norway. So it allows you to grow. You gain. You know, we just watching you at Nigeria. You watching us here. We doing it. So we should be able to mark the 3 level of care. But I said the government gave the policy in 2021, but there was no guideline. And I expect that by now, Ijayi should have a budget for palliative care. FMC does not have a budget for palliative care. It's a tertiary center. They say it should be there, but they are not funding it. So we still need to do a lot of work, you know, to get it there so that people can benefit. And of course, this is a Korean Declaration 2005. Government must make access to hospitals and palliative care as a human right. So many people are being denied rights to see it, to have it there. If you enter the ward and you see 20 patients, I can bet that 30% or 35% of them need palliative care. The pains are not relieved. So it is necessary to stress once again that there must be need for more palliative care center to integrate this care, to see human assistance and spiritual accompaniment they need. And that is what Palliative said. Palliative was very popular during his life. He said it is a right belonging to every human being, one which we must all be committed to defend. You and I have to do it. And you remember when Palliative died, we were watching his life on CNN. People were there for 3-4 days. Distributing water, you were sleeping outside. And Pope said no, he doesn't want to go to the hospital. That they should bring everything you need to his bedroom. The bed, and that's not big deal in you. Many patients have hospital bed in their rooms, they have oxygen in their home. They are not going to that level. And they were keeping vigil because they know that Pope was going. And when it happened, somebody just came from the home that Pope Benedict 16 has passed on. And that was the end of the vigil. You were waiting for him there. That's how supposed to be. Not that your body just died without dignity. No. It's supposed to be. And this is palliative situation in selected African countries. And if you look at the Africa, we have blue, we have green, we have yellow. As you can see the blue. Which countries have that blue?
South Africa,
Zimbabwe. Yes. What does Nigeria have? Well, they're supposed to give us straight. Now, say that this is other started palliative care in the 60s. Could you believe that the first palliative care center, hospital center in Africa was 1975? First hospital, 1975. Do you know where? Zimbabwe. So you see it today. And in South Africa, because I'm very familiar with South Africa. Being in South Africa in 2001, I was living there. South Africa has more than 200 hospices, stand-alone hospices, that I go work and teach there. 200. How many pre-standing hospitals do we have in Nigeria? Anybody tell me? No. Well, I have to tell you, I have. It took me 10 years to build. I worked there for some time. And you are chopping my money. You don't even understand what it's all about. When I retired, I closed it down. The first hospital. I closed it down. It's on 3 floors. When you get it, like ST General School. And yeah, forget it. Because when I was paid, they have more than 200. But you don't have one in Nigeria. Government was not supporting. I spent all my hard money on it to build for 10 years. Like UK said, destruction. Is that everybody? So, Nigeria managed them. And of course, those Arabian countries, when they say they are not African, and that's why you have sub-Saharan Africa. You know that they are not African. So those ones, they don't even have at all. So we are improving. So now, let's analyze the situation in Nigeria. Our strength, political evidence in tertiary health center. Yes, you see. Youth that just started their own last year. Youth. When I got 5 years down, like go to university and start, I went to do the short the door 2006. Youth just started that. You see, became a department 10 years after our home. You see, become a department in 2016. We became a department in 2006. For you to know how people have worked. So hospital based, we initiated it because they came all over, they came from UK, so which money are we going to do? Then we came hospital based, and it's working till today. Play Palliative guys back, they are role model. People like me, they are the role model. We started the national mission in 2007. Opioid availability, and that's why you have to that one day. Come and tell your center how to get opioid and do wonderfully well. The weakness, inadequate manpower. The harvest is fine. So many people need it. But the laborers are few. I want to have more. That is why I am. No formal palliative care training program in the country. National palliative care policy, yes, 2021 we mentioned. No fund, no budget, no municipality office. Sometimes that's more than 200. What are the opportunities we have now that you people will see? Ministry of Health have partial interest. We have palliative care guidelines draft for oncology. I remember, someone has said it by University of Norwich. You know, they wanted to start the trade at the door. One of my colleagues, they also went to use it. And they said we should bring curriculum. We drafted curriculum. We moved. They said, look, I don't think I don't bring best. We done it 3 minutes. Up till now, it has not taken up. Because of what? Politics. They train somebody abroad, they say, until that person comes back, they are not going to start, that person is on salary. You know? And I think that person doesn't funny. I think that person called me last year. Say, okay, I'll finish you, PhD palliative care. See, glory to God. We are expecting you here. You want to start in glory. Say, okay, this is just now. You want me to come? We lost it. We lost it. And I got so many PhD holders in Nigeria and palliative care. This way is not conducive for them to stay. So, some universities, they said they have been created into North America curriculum. It's a lie. CMA meaning like graduate. So CMB, MB are showing interest. After is doing a lot, financial constraint, local. So even here, people are still existing. That's why the fact that so lack of training opportunity, you have to go out. Workload, not financially, career. I'm not making money from it, but I'm spending billions. It's not rewarding. So the application, we have gone through the application. Let me also tell you this one. IBAN. The existential period that mentioned is suffering. He was suffering when he was there, does not respond to medication. He does in them, there is no medication. They gave him opium, morphine. The guy injection of morphine, but did not believe him. It is his servant who provides a healing, empathic presence by his word and action. He will sometimes support his master's leg all night long, affording him belief. That is how we support him. Stay close to them. Because you don't know who we for the glory of. So we need to see. I've not gone through the story of it's something like this. And WHO has been integrated physical, psychological, and social and spiritual well-being as far back as 1948. Nobody take attention to that. Nobody do it. How can you see a patient? You should take care of the physical thing. Don't consider what other people are doing. You are not a complete medical person. You are not. It's not possible. And that's what they said. Who of us? How many of us were alive then? But it was definition. Then in 1998, that's about 50 years, WHO rewrote it. Let's see what the WHO said. Until recently, health professionals have largely followed a medical model that seeks to treat patients focusing on medicine and surgery, less important to believe and faith. Has it changed? Has that changed? It's only political. This reductionism or mechanistic view of patient as only a material body is no longer satisfactory. Patient and clinician will begin to realign the element of faith, hope, compassion in the healing process. The value of such spiritual elements in health and quality of life has led to research in history in an attempt to move forward a more holistic approach that includes a non-material dimension, emphasizing the seamless connection between mind and body. You see how I mean? There is a seamless connection between mind and the body. So let us invite that, please. So what are the pictures of healthcare professionals? Hypocrites. Father of medicine, years ago, he said to cure sometimes you can cure. If you cannot cure, you will heal. If you cannot heal, you will come for the patient. I don't want to bother you, brother. You are doing some doctor. Let's do that. Now, we really want to start. You are welcome. You have shown your picture. You are not there. You show your picture a lot. So, this is palliative care definition. If you don't get the definition, you can never get it. I'll take some time. To digest it for you. It's an approach to improve the quality of life. So many people say their expectation is quality of life. You want to improve the quality of life. Good. But not of the patient. It's patient and family center. When we are managing patients here, the family are sitting at the corridor. And because we close to them, because we want family and family and family center, when the family are beaten by mosquito and they develop malaria, how many doctors or nurses take care of that? We come to us with children. So that patient family center must be in us. We must appreciate what are the family members passing through. So the patient and family center, for those facing problems affiliated with life-threatening illness, and you'll be surprised in palliative care, there is a prevention. It's not a community medicine. We prevent the heat of suffering. Those choices by means of identification and technical assessment, treatment of pain and other problems, physical, psychosocial, and spiritual. We have said to everybody is comfortable with the definition. And this will be your guideline. When you are seeing a patient, you don't take care of the family. You are not done palliative care. When you are seeing a patient, you don't have that impeccable assessment. You know, I was telling you how to decode a human being with cancer. I told you how it goes, how it goes, how it goes, how it goes. You know, without doing tests, you know, that is what we call impeccable assessment. That is, in fact, when you talk about prognosticating a patient, the best people, the best doctor and nurses that can give prognosis to a patient, they are the palliative care people and oncology. If they tell you that this patient is going to pass on the medicines, it's likely because they have seen. They are prognostic saving very, very. We have this. So this is the method we pass. When the patient is not curative, you give palliative care. But now things have changed. Palliative care, you start from the point of diagnosis. Tell your people. When the patient is diagnosed as cancer, you start palliative care. You need a small measure. As the patient gets worse, the palliative care increases. The patient dies. When the patient dies, you concentrate on the individuals and the family with bereavement care. And that is why you have bereavement care part of our treatment. And you can see it better there. Women can support. Now, palliative has been found by Dept and co. that patients with non-small cell cancer, when they give them palliative care, they have significant improvement in both quality of life and mood. That has been validated long ago. But patients receiving palliative care, they have less aggressive care at the end of life but longer survival. What does that mean to you? It means that when you have a cancer patient and you are the patient is already dying and you are getting chemotherapy. You can imagine somebody thinking this way. He wants to go. See, I hope we will recognize there are times when I don't want to talk about that because I don't want to go. I hope my life asks me, what is the meaning? You know, these are parts of pace that we have and you don't even recognize that we have that pain. Let's forget about that patient. Let's talk about simple patient that have appendicitis. They are packaging him for appendectomy. See what is thinking. What is happening to me? I miss my family. Why did this happen to me? Have I been a bad person? You see them find me there and you walk past them. You don't even come and talk to them. Ask them about their anxiety. Ask them about their worry. I keep on telling you at Americans in Abeokuta, if you have any patients from the world, not less than 30-35% of them will give palliative care. We are not saying you give all of them palliative care, but you are going to kill yourself. But please, befriend one or two. So this is a testimony of another man that had a good, you cannot be able to read very well. This is a story we did in FMC 2006. 5 years of patients were feeling that the hospital don't spend time with them. You don't have time, you don't do it. But please be friend one or two. When we started palliative care, I started, I would finish after finishing the work, I would come in the evening to come and talk to them. Sit down with them. 50% of the ones I found that they did not enjoy a close relationship with the staff. The staff, we know you. You will be causing them. They don't allow you to sleep. And look at that. It is the cleaner. It is the cleaner that is cleaning the man. You cannot even face it. Say, how are you tonight, friend? All the better for your company. You don't kill them. That's what it's all about. And Catholic describes something. The state of cigar is straight. Events that threaten interconnect of interconnected physical and psychological aspect of self. This is another breakers in Babylon. That's how you get on. That's the step in staircase on one of the wall. And the lady you see by the side is our psychologist. Came to serve with us. You find time, go and sit down with them. You can see in agony, that boy is a young boy like that. And we also have I don't want to bother you, because you are going to do all this yourself. That's the story of the boy. Progressing neck swelling, orbital extension, finger swelling, you can see weight loss, inability to swallow. You know, metastasis. You can imagine the most terrible thing for somebody is to have increase in intracranial pressure. You can imagine the headache. Cancer of the head is a temple. You wish it for your enemy. You abandon academic, absence of fatherly or small familiar is terrible. It's not good. So these are body of symptoms. In an advanced metastatic ovarian cancer, we were asking before, abdominal pain, constipation, joint pain. There are reasons why you have all these physical problems in the body. Acacia, because it's sleeping there, are always, and that's why we do make diagnosis in palliative care. We identify problems. Now, when we identify problems, we want to know what is causing the abdominal pain. How can we manage the pain? What is causing the constipation? What is causing difficulty in breathing? We are talking about nutrition, loss of appetite, acacia, and these are the problems we try to alleviate and relieve when we are treating them. So other suffering they have, anxiety, we are making all this. Physical suffering, a lot. Mental suffering, grief, apathy, confusion, lots and lots. They are ostracized, bed breathing, social issue. You know, we talk about self and social body being disfigurement last time. Psychological issues. You are going to meet all. Anxiety, needless experiment. Let us look at this slide. This total concept. It's part of what we have talked about. Psychological, physical, social, spiritual. As we go on, we see it. Look at this patient, William, 2004. Can you see what is going on in his mind? It's a terrible thing. And I keep on telling people, whether you like it or not, majority of people will pass through this scenario. Except they are very lucky. One sleep does not wake up. Painless death just go. Except you are very lucky. You are in a plane and the plane crash. Just go like that. Except they are very lucky, they give gunshots on the head. But many people will die chronically like this. So look at what William is saying. Social and social suffering. People talk as if you are not here. Not only the doctor and nurse, even the family. One of my friends died of cancer last week, and people around me were talking all about the funeral. That was concerned them. I'm a paranoid. Like they not even think it might bother me. He gets to me and makes me feel my life is not worth anything compared to God life. Other than carry support. You know, we need to do this. We need to know what is happening. It is very, very good. We have talked about this sources of suffering, the disease, suffering, the financial issue, the families, they don't have money, the cultural aspect. I was in India. In India, when the cancer patient come to the clinic, and you find out what it's all about. This, my friend, is a consultant is placed in wait. We consultant palliative care physician. We ask the patient to step outside. And we break the bad news to the family. And that was not the way I was taught. And I couldn't believe him because it was his claim. He had that diploma in palliative medicine from the University of Wales, not palliative care. But I couldn't, so I just I was struggling with it. I asked him, the patient must know, because we are going to do break bad news. Break the bad news. The patient must know what is wrong. When you want to break the bad news, you send the patient outside. Why? It is right to know. He said no. In this environment, the culture does not allow it. So you must also know where you are working. The culture does not allow it. What the culture is that you tell the family member. Will be ignored. And for all their knowledge, what they have done, right about they cannot change that because their cultural ethics. Also doing. So culture is also very important. The facility and the resources, there are some facilities, they don't have the facility, they don't have the resources. Manpower is not there, that's why we are trying to improve the manpower. Now we have policy. Please say the policy to your people. But what are the policy challenges? Delay in diagnosis, treatment, you don't have doctors, you don't have nurses, therapeutic failure, bureaucracy, strategy to allow to alleviate some people do all this. Policy was not there, policy is now. And of course, from what all we have done is multidisciplinary gap. Everybody needs to be there. Take the record, the intervention, the coordinate, the other things. These are part of the psychological issues. And Complarons, 5 stages of grief. Everybody knows that. You know. So it also comes like, okay, you say, look, you have cancer of the breast, you have cancer of the brain. In fact, you have cancer of the liver. He doesn't see. He said, no, I don't have cancer of the liver. Denial, disbelief. Then later the things start to growing, to become angry with himself, or his HIV patient say, oh, that useless man gave me the HIV. Angry, later he begins to be, he goes into depression, accept it, and he will come back and not accept it. So we use it a lot. In the case of depression, in a small child. So grief and bereavement, we have a section on it, I think tomorrow. We talk about extremely grief, complicated grief, bereavement, period of laughter loss, share experience with you, and these are part of the normal grief. When you have a normal grief, when somebody has a complicated grief, you know, psychological issues, spiritual and existential suffering. So we are going to go to so we have a lot to do. We have a lot to do. But we don't have enough time. I don't want to bother you about this. This is a model of pain. Culturally, in Hausa land, I've talked to you about it in India. Culturally, in Hausa land, when the woman is in labor, she must not cry that she has pain. In their own culture. So when she doesn't cry that she has pain, you think they will give an attention to that woman? No. So it depends on when you are practicing. So the unexpected pain is the initial part of life, and this is the definition of pain. We normally use a common definition. That this definition in 1979, we are changing now in 2020, and it's defined.
I was just looking for the inner voice.
Yes, we want to use this opportunity to welcome the medical director, represented by the head of clinical services, Dr. A.S. Adeokuta. You are welcome to this program. You are also welcome. So we will do the welcome address proper by the MD, represented by the ACS, Dr. A.S. Adeokuta. Thank you, sir. Yes, sir.
Does this label or it's more than what? And I'm not fair for silver. So my Oga at the top, Dr. Imola, it's a pleasure to have you back in your father's land. So I want to be looking at this thing. I'm going to start So yeah, I hope you have acclimatized a little, because I know it. We are just back to the temperature of this environment. So the AD nursing, I see Mrs. Only there. It's a pleasure to have you here. Other the Department of Pain and Palliative, head of Department of Mental Health and Behavioral Medicine, other heads of department will be represented that I'm seeing. I can see my colleague there, the distinguished colleagues, consultants, other very senior nurses who are here present. Distinguished ladies and gentlemen, please permit me just accept the protocol as I've established it, because I know today is not the day of the protocol. Today is the day where when we really need this, and I can see when we look from my pieces that we are all there for such visits. It must be a very serious process, something that will bring a big shift like this from the whole of the United Kingdom to come and share his experience with us. And there is no doubt that as healthcare personnel, we need to continuously train ourselves. We need to continuously improve and sharpen our skill. The aim of that is to make sure that we continue to improve on the quality of the care that we deliver to our patients. And I know that it is on account of that in his characteristic and hiring manner that we are in his team, wherever he is on the face of the earth, continue to strive to make sure that we continue to attract knowledge, skill, information, and training that will help us to improve our services. And it's on that account that the medical director gladly accepted when he brought up the proposal for this training to take place. And as we know, it's a very academic minded interested in continuous training and training. But he has to attend the very important program in Abuja this morning that he can do from this center. And we are graciously sent and I myself, I think when we had this kind of program on years back, I think maybe 4 or 5 years ago, the resource persons. And we have really a big part of it would have really felt to be part of the resource persons there, but I understand that Dr. Wimola's more resourceful person now, that he has decided that I'm no longer listening to him. I'm not agree with that. It is said acceptable to me because I know that the thing that he has put together is a paper that will do justice to the various topics regarding the pain management in our patients, both children as well as adults. I know today is not a day of switch, so I'm not like to take too much of your time. Let me just say that I welcome you heartily. I can see from the news on your faces that you have already started enjoying the program, and I know that you will continue to enjoy it as well as to accumulate knowledge. I know that at the end of the day, it will be of immense benefit to our team patients when we move back to our various clinics and our various sports. On that note, let me thank Dr. Ibola for coming to deliver this to us. Let me also thank all of us for enthusiasm, and I'm sure that we will thank you very much and have another day.
Tommy, you know that it's not easy to take big risks out of their seats. And the director of nursing services, you are welcome now. We appreciate you. Nicely, we are looking. Thanks so much for the support. We are always there for us. You don't know whether you are busy or you just want to. But in fact, we are very busy, you know. So we don't want to disturb you.
Thank you very much.
So thanks so much for coming. What about
so you can join us outside.
So, everybody has heard this. Everybody has heard it and you are familiar with it. It has changed. But let's hear is that pain is subjective. It's not objective. When the patient is on the wall, I say, oh, pain. No, what is your pain? We are giving you metazocine. Why are you crying? You have an increase not. So, and most of the time pains are underrated. Because what you want to keep, not only diagnosis, you are going to give a very long medication. Pain management is a fundamental one. Nobody must have pain. Ensure he has pain on your wall. And we have regarded pain as the fifth vital sign. When you do the picture, do all those things, ask your patient, you have pain. So you know what to do. So the total pain, I'll show you the picture. Is holistic. I think with this model, biopsychosocial model, biopsychosocial spiritual, biopsychological and socioeconomic in Nigeria. Because the financial stress give people pain in Nigeria. Unlike other countries where you have health insurance, you don't even need to pay for anything. Then there are other factors. So I don't want to go into this. We don't need to stress our head. The physiology, anatomy of pain. We don't want to stress ourselves. Now let's go to
cancer patient. Infection can cause pain. Even other hepatitis will cause pain. Debility, low back pain. Even treatment can cause pain. Cause pain. Chemotherapy will cause pain for them. You say you are treating them, you are giving chemotherapy, they will develop pain with it. So they are always surrounded by pain. And pain can be divided into acute pain, chronic cancer pain, chronic non-cancer pain. Chronic cancer pain, all of us know. What is chronic non-cancer pain? Example of chronic non-cancer pain. You don't treat everything as cancer. An example of chronic non-cancer pain. Chronic liver pain, okay? Chronic non-cancer pain. Arthritis. Huh?
Yes.
Yes. Sickle cell pain. Yes. And when they are becoming chronic, you know that you cannot use the usual thing to manage. And if you go into palliative care definition, you see, of all the symptoms, it's only pain that is mentioned. So pain is very crucial. But we have seen this, total pain, the body, mind, spirit, and all those things. So pain could be devastating, dehumanizing, loss of dignity, low quality of life, subjective, but you must keep your patient free of pain at night, must be free of pain at rest, must be free of pain on movement. How will somebody who has metastatic bone cancer not have pain when it's moving? You have to control it. As usual, we take history, we do examination, we investigate, we make diagnosis. Usually, they don't have one pain. Let us take the hypothetical condition talks, cancer of the breast. He has pain on the bone. He has pain on the chest. He has pain as a result of the cancer. So they may have, multiple number of pain. So if somebody has about 5 different pain, and you just do one, you are not going to treat that patient very, very well. It's just not possible. So we thought about the time, we thought about the severity, what relief pain, what causing pain, what is the quality of the sleep, of the pain, how does it impact patient's sleep, mood, what is the meaning of the pain to the patient. Some will tell you because it's a sinner, or some